Hi, I'm Kelly Walkovich, a pediatric hematologist from the University of Michigan. On behalf of our NICER community, I welcome you to the NICER Education Camps, an adventurous educational initiative in immunohematology. Here we utilize a multi-specialty approach to delve deeply into common patient problems, integrating the latest insights and valuable perspectives from our experts that you won't want to miss. As you enjoy this session's talks, be sure to join us live for the Fireside chat. There you can directly engage with our experts and ensure all your questions and curiosities are explored. Whether you're a senior camper or a newcomer, there's always something fun to learn with NICER. Today's session will be moderated by Chris Failing, a pediatric rheumatologist and assistant professor at Sanford Health University of North Dakota School of Medicine, and Nadine Saad, a pediatric rheumatologist and assistant professor from the University of Michigan.
Hi, everyone. I'm Chris Failing. For today's session, we're going to focus on autoinflammatory bone disorders, an important intersection between rheumatology and the rest of the immunology community. We're excited to have three speakers with us today to display the multidisciplinary approach to lytic bone lesions. Including our speakers today, we have Dr. Saad, Anastasia Hryhorczuk, a pediatric radiologist, and Polly Ferguson, a peds rheumatologist and world-renowned expert in CRMO. I'm very excited to introduce our first speaker, Dr. Saad, a pediatric rheumatologist at the University of Michigan. She also serves as a program director for the Peds Rheumatology Fellowship and is also a member of NICER and one of the educational leads for the NICER education camps.
Good morning. My name is Nadine Saad. I'm a pediatric rheumatologist at the University of Michigan, and I'll be starting off this morning's education camp talking about lytic bone lesions and a diagnostic approach. To begin, I have no relevant financial disclosures for this talk. And the objectives for the learner this morning, at the end of the talk, my hope is the learner will be able to develop a differential diagnosis for lytic bone lesions, and then to also create an evaluation, including relevant labs, imaging studies, and biopsy studies to work up lytic bone lesions. We'll start off with a case of a 12-year-old female who was referred to our pediatric rheumatology clinic for left thigh pain and swelling for 4 years. So obviously we don't have too much to go off of so far. We know that it's localized pain and it's chronic, but we have to ask more questions to kind of clarify more symptoms. So what we learn is that she also has knee pain. As a rheumatologist, I kind of always think about arthritis, and so I ask about inflammatory symptoms. And those would be symptoms such as swelling, warmth, stiffness of joints, especially after periods of inactivity, and that improves with activity. And she doesn't have any of those. Thinking of localized pain, she has no preceding injury, but of course this was 4 years ago, but nothing that sticks out to the patient or the family. There is no preceding illness. She has no systemic symptoms such as fevers, night sweats, weight loss. And she is a very active dancer for many years. And throughout this time, she kind of attributed the pain to growing pains and just dance pains. But it's been going on for such a long time. And now that she has swelling, she sought medical attention. Otherwise, she looks great. She's growing and developing appropriately. So on exam, she's well appearing, afebrile, has normal vital signs. She doesn't have any axillary or cervical lymphadenopathy, does not have hepatosplenomegaly, and she has no particular rashes. And really the only thing on exam is that she has this localized soft tissue swelling, firmness over her left distal thigh, no overlying skin changes, and the rest of her exam is pretty unremarkable. So in the clinic, something we can do quickly is to get an x-ray. And when we get an x-ray, what we can see from her thigh is that she has this mixed lytic and sclerotic lesion extending from the mid-diaphysis to the distal metadiaphysis. And you can also see on the lateral view cortical thickening and bony expansion. All right, so we have this x-ray finding and it's pretty unexpected. So where do we go from here? Now, when we think of lytic bone lesions, how I like to think of them are the differential in like broad categories. Of course, these categories won't cover all diagnoses, but they are pretty broad that they'll capture quite a few. And how I think of them are benign lesions, malignant, metabolic, infectious, inflammatory, where autoinflammatory rheumatologic conditions will fall under this category. And then another category of rare or genetic or like kind of other conditions causing lytic bone lesions. To begin with benign lesions. These are some benign lesions. This doesn't encompass all of them, but some of the more common ones that we'll see are a unicameral or simple bone cyst, an aneurysmal bone cyst, fibrous dysplasia, or a non-ossifying fibroma. And what's nice here is that when we're diagnosing benign bone lesions, typically the combination of the clinical history plus plain films will kind of lead us to the correct diagnosis. So for example, in a simple bone cyst, typically we're looking at patients who are younger than 30. There's a well-defined lytic lesion, and it typically occurs in the proximal humerus and the femur. In an aneurysmal bone cyst, again, patients younger than 30, but there's typically an expansile lytic lesion. With fibrous dysplasia, there is no particular age where it occurs, but it's a well-defined lytic lesion, commonly occurring in the ribs, the pelvis, and extremities. And then with non-ossifying fibromas, again, younger patients, but this typically occurs in the metaphysis of long bones. So that's to say not only the particular X-ray finding, but also the location, the patient's age can all help to diagnose a benign bone lesion. Moving on to malignant bone lesions, we have osteosarcoma and Ewing sarcoma. Again, we're thinking of younger patients. So for osteosarcoma, 75% occur before the age of 20, and we can see that common Codman triangle on imaging. With Ewing sarcoma, commonly occurs between the ages of 5 to 25. It's a diaphyseal lesion, and it has a moth-eaten appearance. With lymphoma of the bone, again, occurs in the diaphysis. And then with metastatic disease, that can cause multiple lytic bone lesions, but typically there are other, whether it's constitutional symptoms or other organ involvement, to lead towards a diagnosis of metastasis. Just to briefly talk about a couple metabolic causes for lytic bone lesions. This again doesn't encompass all metabolic causes. One, though, is hyperparathyroidism. So PTH, parathyroid hormone, has an important role in bone remodeling. And what can happen with hyperparathyroidism, whether it's primary, secondary, or tertiary, is brown tumors can form. And this causes normal bone architecture to be replaced by focal cyst-like accumulation of fibrous tissue. And then another clue on imaging that the lesions are due to hyperparathyroidism are the findings of bone resorption and osteosclerosis. Another potential metabolic cause is Gaucher disease. So this is autosomal recessive. It's a deficiency of glucocerebrosidase, which leads to an accumulation of glucosylceramide in macrophages. In addition to bone lesions, some other clues to the diagnosis would be cytopenias, splenomegaly, and hepatomegaly. So now we've talked about these first three benign, malignant, metabolic reasons for lytic bone lesions. The rest of my talk is going to talk more about infectious and inflammatory, but I wanted to make a note just about rare and genetic causes. Just two to kind of point out, there's Gorham-Stout disease, which is osteolysis and also abnormal proliferation of lymphatic vessels. This kind of causes vanishing bone disease, where the bone can be either affected a single bone or surrounding soft tissues or adjacent bones. It presents as bone pain, swelling. There's a risk of fractures. It can occur in the skull, the clavicle, the vertebrae, the pelvis, or the ribs. And then lymphangiomatosis of the bone. This is something that I ran into with one of my patients where it took 4 or 5 bone biopsies to make this diagnosis. And the reason I kind of highlighted it here is just to point out is that a lot of times, especially when we're talking about inflammatory bone lesions or in the infectious category, we do bone biopsies, and sometimes we may not have a conclusive diagnosis from the first or second biopsy. And sometimes we have to empirically treat for a particular diagnosis, but if someone is not improving as you expect them to, then doing another bone biopsy may be important. All right, so now as a rheumatologist, when I think of lytic bone lesions, I kind of think of the big 3 conditions. So there's infectious osteomyelitis, chronic non-infectious osteomyelitis, and then I also chose Langerhans cell histiocytosis. And the reason I highlighted the 3 of these is because there's quite a lot of overlap in terms of the symptoms, in terms of where they occur for the lesions, and kind of having that chronicity to the symptoms. Okay, so just some pearls about infectious osteomyelitis. We can split it into both acute infectious osteomyelitis and chronic. With acute, we think of a bone infection within 4 weeks of clinical manifestations in a bone that was previously uninfected. With chronic osteomyelitis that is infectious, you have a more protracted or indolent disease, and then there's a presence of either a sequestrum, which is when necrotic bone tissue kind of breaks away from healthy bone, or there's a relapse of an infection in the same bone that was previously affected, whether it's weeks to even years later. Some important risk factors to note for infectious osteomyelitis include immunodeficiency, sickle cell disease, trauma, and indwelling foreign bodies. And then very similar to other bone lesions, they'll present with bone pain, swelling, reduced ambulation. But one feature here is that fevers, and they may be kind of low grade or even high fevers, would be a differentiating factor of infectious osteomyelitis from other bone disorders. Typically, infectious osteomyelitis occurs in the metaphysis of long bones. And then an important point to note, and this is not only for infectious osteomyelitis, but in general, osteolytic lesions take a couple weeks to appear on radiographs. So at some point, if you were to obtain x-rays in the initial presentation, the acute presentation, what can happen is you may have normal x-rays, but if someone persists in terms of having pain, it would be important to repeat the x-rays because then you may see the lesions later. To review some of the common organisms that we see with infectious osteomyelitis, Staph aureus is the most common. We see Kingella kingae in preschool-aged children, and then we have other bacteria such as Strep pneumo, Streptococcus pyogenes, and Mycobacterium tuberculosis. With our immunosuppressed patients, we may see infectious osteomyelitis from gram-negative bacteria, fungi, or even atypical Mycobacterium. To move on to Langerhans cell histiocytosis, some pearls here is that LCH is a clonal neoplastic proliferation of Langerhans cells, and they express CD1A, Langerin, and S100 protein. The clinical manifestations can vary widely from just single organ involvement that's mild to very severe multi-system disease that's life-threatening. The skeleton is the most affected area, with 80% of cases of LCH presenting with bone lesions. And then I highlighted 2 mutations that we can see. So one mutation is the BRAF V600E gene, and that's the most common mutation in LCH. It occurs in 50 to 60% of cases and leads to continuous MAPK pathway activation and leads to uncontrolled Langerhans cell proliferation. Another mutation that we can see is the MAP2K1, and that's again really leads to uncontrolled proliferation. What's important to know for LCH is the diagnosis involves a combination of clinical assessment, histopathology, immunohistochemistry, molecular testing, and imaging. Thinking of histiocytic disorders, I just want to mention Rosai-Dorfman disease. This is characterized by proliferation of large S100 positive histiocytes with lymphocytophagocytosis of lymphocytes, plasma cells, or neutrophils. I just want to note that there is a classical nodal form and an extranodal form. With classical nodal, cervical lymph nodes are the most commonly affected, but other lymph nodes can be involved as well. And it typically presents as bilateral, painless, massive cervical lymphadenopathy. For extranodal involvement, that can affect the skin, nasal cavity, bones, soft tissue, retroorbital, the GI tract, kidneys, genitourinary tract, and the respiratory system. And approximately 50% of these lesions have mutations in the MAPK or ERK pathway. And then I also want to highlight, in terms of the different classification for Rosai-Dorfman, there is immune disease associated, which are linked with lupus, idiopathic juvenile arthritis, and autoimmune hemolytic anemia. So now that we've talked about infectious osteomyelitis and LCH, I want to just mention autoinflammatory bone disorders, and there's quite a few. What I'm most going to focus on is chronic non-infectious osteomyelitis, but there are some other ones to be aware of. And this goes through the different autoinflammatory bone diseases. So we have the ones that are monogenic here on the left, and then the multifactorial ones on the right, where we have CNO, non-syndromic CNO, and Sappho syndrome. And what we also know is that IL-1 and TNF-alpha play different roles in these conditions. So more with the monogenic diseases, there's more of a role of IL-1, with, for example, with DIRA and Majeed syndrome. In cherubism and Sappho syndrome, there's more of a role of TNF-alpha, and then CNO is somewhere here in the middle. So this goes through the pathogenesis of the autoinflammatory bone disorders. So there are genetic mutations, maybe there's an infection, a lot of unknown triggers that affect the peripheral monocytes. And what happens, there's a decrease in the anti-inflammatory cytokines, and there's an increase in the pro-inflammatory cytokines, which increases this interaction of rank and rank ligand, leading to osteoclast activation. And now with some other autoinflammatory bone diseases, you can also have joint involvement, skin, and GI involvement as well. All right, so now that we have our differential for the lytic bone lesions, we have to decide how we're going to work them up. So plain films are a great place to start. Again, like I mentioned in the beginning of the talk, sometimes with the benign lesions, just x-rays alone will make our diagnosis. Sometimes, though, we do need advanced imaging, whether it's MRI or PET-CT for malignancies. In terms of MRI, it's helpful to MRI the particular area, but in a condition like chronic non-infectious osteomyelitis or CNO, you can have silent lesions in the spine, close to growth plates, in the long bones. And so without a whole body MRI, we won't know lesions are there. And then if the lesions are in the spine or next to the growth plate, there is a risk of either fracture or poor growth. In terms of labs, as you can imagine, there are no particular diagnostic labs that we have. We can get basic labs to look at the CBC, inflammatory markers. Procalcitonin blood cultures can be helpful if you're thinking of an infectious cause. And then PTH, serum calcium, and vitamin D would be helpful looking at metabolic reasons for lytic bone lesions. And one thing that can be very helpful is getting a bone biopsy. In terms of what to look for in the bone biopsy, there's infectious studies, so gram stain, aerobic and anaerobic cultures, and then staining for S100 and CD1A for Langerhans cells. Circling back to our case, we obtained labs on our patient. Her white count was 7, ANC 3800. She had a slight anemia, but her platelets were normal, her comp was normal. She had a slight elevation in her inflammatory markers, and her LDH and uric acid were normal. So far, we know that she has these lytic bone lesions, and the labs are not very specific. We moved forward with getting a bone biopsy. That showed focal reactive changes in fibrosis, and then the culture grew Cutibacterium acnes, and so she was treated with 3 months of amoxicillin. But her symptoms persisted, did not improve, so she had another bone biopsy 5 months later, which showed reactive bone. This time cultures were negative. And she additionally had a whole body MRI that identified lesions in the tibial diaphysis. So taking this all together, she has a lesion in her thigh, in her tibial diaphysis, not improving with antibiotics. Infectious studies were negative on repeat. So this led us to a diagnosis of chronic non-infectious osteomyelitis. Now, in a later talk this morning, you'll hear more about treatments in autoinflammatory bone disorders, but just to describe this patient's treatment course, she was initially treated with methotrexate, didn't have full improvement, so Humira, a TNF inhibitor, was added on. What happened for her is that she developed psoriasis while taking Humira and developed gum swelling with methotrexate. So she was actually switched to golimumab, which is another TNF inhibitor, improved with golimumab, but still had a persistence in her lesion. So pamidronate, a bisphosphonate, was added for a few months, still didn't have a clear resolution of her lesion. So stayed on the golimumab. After stable MRIs over time, we decided to stop her golimumab, and this was very recently. So she's considered inactive disease right now, and the plan is to follow up her imaging in about 4 to 6 months to see if she can stay off of treatment. So my take-home pearls for lytic bone lesions is that the approach should be tailored to the clinical picture. Plain films can be a great first step to make the diagnosis or lead the workup in a particular direction. A multidisciplinary approach is very useful because the presentation amongst different diagnoses can be very similar and have a lot of overlap. And imaging and/or bone biopsy are crucial to make the diagnosis in many cases. These are some helpful references. And thank you for listening this morning. I would like to now introduce Anastasia Hryhorczuk. She's a clinical associate professor of radiology, the associate chair of the section of pediatric radiology at the University of Michigan, and the radiologist in chief at the C.S. Mott Children's and Women's Hospital. Dr. Hryhorczuk has published many peer-reviewed papers and is involved in national organizations, including the Society for Pediatric Radiology. Thank you, Dr. Hryhorczuk.
Good morning, everyone. My name is Anastasia Hryhorczuk. I'm an associate professor of radiology at the University of Michigan, and I am here to talk to you today about the radiology of autoinflammatory disorders in bones. I have no disclosures today for our lecture. So there are three major objectives of our lecture today. First, we're going to talk a little bit about the normal development of pediatric bones and bone marrow, because looking at that is really essential to having a sense of what is abnormal when we want to look at pathology. Then we are going to explore the imaging of specific autoinflammatory disorders of bone that are seen in children, and focusing on two main entities. First, chronic recurrent multifocal osteomyelitis, or chronic non-infectious osteomyelitis, CRMO or CNO, and then Langerhans cell histiocytosis. And finally, we're going to compare and contrast the imaging appearance of bone pathology that we see may mimic an autoinflammatory bone disorder. So we're starting out here by reviewing our normal development of pediatric bones and bone marrow. With pediatric ossification, we see a very complicated development of our long bones, and we're going to start by talking about our long bones first. What happens with our long bones is that this is kind of a example of what happens with the long bones, and we start with a massive embryonal cartilage that serves as the initial sort of primordial part of the long bone. And then the central cartilage cells enlarge and multiply with a central chondrification center. We then start getting some ossification within the center of the long bone. The medullary cavity begins to become reabsorbed over time. By the time we move towards birth, and afterwards, we may start getting some of the epiphyseal ossification centers in these long bones. And then as the child grows to maturity, eventually we see fusion of the physes. We see a medullary cavity in the center of our long bone and the metaphyses and the epiphyses, as we expect to see in our older children. And when we talk about what we're going to be seeing at imaging, what we typically will see is we see the ossification of the epiphyses that occur over the child's growth, and the growth of the long bones occurs at the metaphyses. So we're looking at some images of a tibia and a fibula from a newborn to a 13-year-old. And we can see in our newborn here, we have the fibula, we have the tibia, and we see only one ossification center here of an epiphysis, which is this proximal tibial epiphyseal ossification center. As we move on to having a 2-year-old, we can see that that ossification center has grown in size and is beginning to conform to the adjacent metaphysis. We also have the development of new ossification centers of the distal tibial and fibular epiphyses. By the time we have a 5-year-old here, we now see that we have progressive growth of all of these epiphyseal ossification centers with corresponding and reciprocal molding to the ends of the long bone and the metaphyses. And by the time we have a 13-year-old, we can see that we're already getting some fusion of the physis here and having more of the typical appearance of bones that we think about in the adult population. As we move on, we're going to also think about the hands and the feet, which are a little bit different. In the hands and the feet, we have cartilaginous carpal and tarsal bones that ossify in this progressive manner. So let's take a look at our foot of a 2-month-old, a 2-year-old, and a 12-year-old. What we can see through this is that in our 2-month-old, our tarsal bones are just really these kind of rounded balls of ossification. We see the talus and the calcaneus in the hindfoot, and we have this single ossified area of the cuboid in the midfoot. By the time we have a 2-year-old, we can see that the talus and the calcaneus are developing more of their typical shapes. Our cuboid is much larger, and we have ossification of these cuneiforms. And by the time we have a 12-year-old, we have a more mature appearance of the midfoot, more typical what we see in the adult population. So these are really important to know because this is what we're going to be seeing in our imaging, and knowing the normal appearance is really critical for being able to identify when something is going amiss with these osseous structures. We're also going to talk a little bit about what happens with pediatric bone marrow. So, when an infant is born, they have essentially full hematopoietic marrow throughout their bones. But what we're going to see over time is that this hematopoietic bone marrow converts to fatty marrow and a more typical adult appearance of the bone marrow. But it follows in a very consistent pattern. And there are two main principles that you want to remember. First, distal portions of an osseous structure are going to be converting to fatty marrow before a more proximal portion. So, a more distal bone, a more distal portion of a bone is going to be getting that fatty marrow more rapidly than the proximal portions of the bones. And in the long bones, we see a very specific pattern of marrow conversion. The epiphysis converts from red marrow to fatty marrow first. The diaphysis converts afterwards in a distal to proximal fashion. And then the metaphysis is the final area that converts into fatty marrow. And in fact, in the proximal metaphyses of some of the more central long bones, the femur and the humerus, we see that that red marrow is still retained partially even into early adult life. So, this is a schema from the literature showing that we have in infancy essentially all red marrow throughout the bone. By the time we have a younger child, we'll see fatty conversion of the epiphyses and the epiphyseal equivalents. And in the diaphysis centrally, we start to see fatty marrow conversion. By the time we have an adolescent, we've gotten conversion throughout the diaphysis with just a small amount of residual marrow in the distal metaphysis and a larger amount of red marrow within our proximal metaphysis. Again, following this first rule here that we convert distally before proximally. Finally, by the time we get to adulthood, this distal metaphysis should be primarily fatty marrow, and a small amount of red marrow is preserved in the proximal metaphysis. So, these principles are just really important to remember. And we'll take a look at this on an actual MR image. This is a 3-week old, and these are T1 images of the marrow space in a 3-week-old and a 6-year-old. So, what we know is we know that hematopoietic red marrow is going to be very similar to muscle on T1 and maybe a little bit brighter in signal on T2. Fatty marrow is going to be bright on T1 weighted images. The images that we see here are both T1 weighted images, and we can see here that this 3-week-old has their tibial shaft, I'm going kind of around the margin of the tibial shaft here, which is to the left of my cursor. And we can see that this shaft is all low signal, very similar to the adjacent muscle, which we see within the mid portion of the calf. When we go to the 6-year-old, we can see the adjacent muscle here, and we can see the adjacent marrow signal in the tibia here. And we can see that this has now become bright, much more similar to the subcutaneous fat. This is fatty conversion of this marrow. And when we look at the metaphysis more proximally here, we can see that this has a little bit of that darker appearance of the marrow there, which is just that small amount of red marrow hanging on in the proximal metaphysis of the bone. When we see the adjacent ossified epiphysis, we can see that this has the fatty marrow signal. So these are the principles that we are thinking about when we interpret these images. In older patients, we talk about seeing some residual red marrow holding on at the metaphysis. People talk about this as having almost a flame-shaped appearance, and it's something that we can see in older teams. On the image on the right of the screen, we see here that this is a 16-year-old with a history of CRMO. And in comparison to the epiphyses here, we can see that the metaphyses are a little bit lower in signal and have these kind of elongated flame-shaped appearances of the dark signal here. In an 18-year-old with possible arthritis, who we did a knee MR on, we can look and see that there's darker signal here in the metaphysis when compared to the adjacent epiphysis, a little bit of this triangular appearance compatible with that flame-shaped metaphyseal residual red marrow. In the hands and feet, it's really important to think about this in the hind foot and the midfoot primarily. These are places that can have tiny foci of red marrow within these tarsal bones that can be retained for a long time. And you want to really distinguish this from marrow edema. So we look at the images on the left of the screen, our 13-year-old with chronic foot pain. And we can see here on our T1 weighted image at the top, we see these slight low signal areas with high T2 signal. These are just little foci of some residual red marrow. This is a 15-year-old with foot pain, and all through these tarsal bones, we see these slightly lower signal areas within these bones. This is on a T1 weighted image. And when we go to our fluid sensitive sequence here, we can see that they're just very spotty little areas of higher fluid signal, not more confluent or large areas of edema. And this all goes along with having small residual foci of red marrow within the hindfoot. Okay, so now that we've taken a look at the marrow signal that we see in typical bones, we're going to switch our gears a little bit and move into the discussion of how we image patients with autoinflammatory bone disorders. For the most part, we do a lot of radiographs in these patients as well as MRIs. And we're going to start with chronic recurrent multifocal osteomyelitis, CRMO. And in these patients, x rays are typically normal early. That's why we do a lot of work in these patients with MR and whole body MR, especially because several of these patients may have lesions that are clinically active but not manifesting in symptoms yet. But later, when we have a more established disease, we'll see lytic lesions. This is the case of a 10-year-old who had ankle pain, and we can see in this patient's ankle, we see 2 lucent lesions, one more medially and one more laterally, that are apparent on our plain film and very readily visible on this MR. When we get to our MR imaging on the right of the screen, we can see we have axial T1, axial T2, and axial post-contrast images. On our T1 weighted images, we can see the lesion medially and laterally. These both demonstrate marrow signal that is lower than the normal fatty marrow that we see in the adjacent metaphysis. When we go to our T2 weighted imaging, we can see that there is edema in these lesions and surrounding the soft tissue. And on our post-contrast images, we can see that both of these lesions are enhancing And that post-contrast enhancement extends into the soft tissues, which have extensive adjacent inflammation. In these patients, this appearance could be very similar to a patient who has infectious osteomyelitis, and it can be difficult to identify this on our initial imaging. Oftentimes, infectious osteomyelitis will also involve the metaphysis and also involve very similar marrow signal changes on these images. When we talk about patients with CRMO, one of our most important things that we want to think about is the location of the lesions. The metaphyses and the epiphyses of the lower extremities are some of the major places that we look to see these lesions. Tibial involvement is very common, and we see this in about 70% of the patients. And about 40% of our patients will have symmetric lesions. So when we do this whole body MR, that's why it's really nice to be able to see side to side and compare what we have in the lower extremities. Another place that we typically talk about seeing lesions is in the shoulder girdle and the clavicle. This is present in about 40% of the patients. And clavicular lesions are especially important because, as we know, these can be a solitary lesion and can be very suggestive of chronic recurrent multifocal osteomyelitis in the correct clinical setting. Spine lesions are another common place that we see disease. These can be seen in up to about 20% of patients, and about a third of these patients are asymptomatic. We'll see sclerosis within vertebral bodies, as well as compression deformities, even passing to a full vertebra plana configuration. What's important, though, to note when we see spine lesions is that typically we should not see a soft tissue mass, and we should not see a spine lesion crossing the area of the disc. Finally, mandible lesions are one of the places that we also look for disease. These are less common, but like the clavicle, these can also be a solitary site of disease. So we're going to start by looking at some of these typical lesions. And this is a 7-year-old who had chronic multifocal pain who received these images on a whole body MR. So when we look at these knees, we see right knee, left knee, right knee, left knee. And as we're looking at this, we can see that there's abnormal signal within the metaphysis. This is very dark. This isn't just that little bit of slightly darker marrow signal. This is really, really low signal. And we're seeing that it's symmetric side to side, symmetric in the proximal tibias as well. When we move on and look at our fluid sensitive sequences, we can see that there is symmetric edema within the bilateral distal femurs. And we also see there is some involvement of the epiphyses here with bilateral edema here in these medial tibial epiphyses. We see a similar pattern within the distal tibias bilaterally with this marrow edema as well as some epiphyseal edema. And when we look at this, we can see that this is fairly symmetrical side to side. And this would be a very good appearance for chronic recurrent multifocal osteomyelitis in a child. Another place we talked about typical lesions is the clavicle. This is a patient who had clavicle pain in the right mid clavicle. And we see at the top of our image, we have clavicle radiographs. I think these can be very difficult to look at because there's a lot of overlap in this medial clavicle where we typically see disease. But on the left side, you can follow the undersurface of the clavicular shaft here on the superior aspect of my marker, and we can see it intact here. When we look at this right clavicle, which was the symptomatic side, it looks like there's a bit of a periosteal reaction and a soft tissue mass splaying this clavicle. And we don't see the margin of the clavicle clearly here at the medial aspect. And this patient had a palpable abnormality. When we move on from our plain films to get an MR of this patient, we can see on these post-contrast T1 weighted images that we have significant enhancement surrounding this clavicle and enhancement within this marrow cavity. On our fluid-sensitive T2 weighted sequences at the bottom of the slide, we can see that there's very significant edema surrounding this medial clavicle. And this is a very typical lesion and a typical appearance for CRMO. This was the only lesion identified on a whole body exam for this patient. So that's another thing that we saw on this patient that was typical. So, this is a spine MRI of a patient who has typical CRMO lesions throughout their spine. And we see this as a full spine MR that was obtained, I think, after this patient's whole body study because of the significance of the spine findings. We see T1 weighted images, T2 weighted images, and post contrast images. I'm going to start by suggesting that we look at these mid thoracic vertebral bodies here. These have a normal T1 weighted signal where we see slight hyperintensity, but not as dark as muscle, not as bright as the subcutaneous fat, also with normal signal on T2 weighted and post contrast images. And let's contrast that to some of the other vertebral bodies that we see that have multiple different findings that we see with CRMO. So we can see at our T7 vertebral body here, just above my marker, in comparison to these lower thoracic spine vertebral bodies, this vertebral body has slightly lower marrow signal. On our fluid sensitive sequences, we can see that there's marrow edema there. And on our post contrast images, we can see that there's significant enhancement in the adjacent soft tissues. This goes along with having a CRMO type lesion, but not yet with vertebral body height loss or sclerosis. So we see here, immediately inferior to the C7 vertebral body, just above my marker, we can see that there's this very tiny wafer of signal here between the two disc spaces. And this is the collapsed T1 vertebral body here, which has a vertebraplana configuration. We can barely see the enhancement between this. Finally, we see another vertebral body here at the T3 level, where we can see that there is slightly lower signal on our T1 weighted imaging, edema on our T2 weighted imaging, as well as partial height loss. So, between these vertebral bodies, we see a variety of different findings that we can see with CRMO, including just marrow changes, inflammation, and edema, collapse with partial height loss, and then the vertebraplana, which we're seeing at the T1 level. Finally, we're going to take a look at a CRMO lesion in one of our other typical sites, which is the mandible. Here we can see this is a 14-year-old with right jaw pain. We have T1 and T2 weighted images. In our T1 weighted image, we can see that there is lower signal within the right mandible here, as compared to the left, where we can see this slight fatty marrow signal. On our fluid sensitive sequences, we can see that we have this edema within the right mandible and not the left. This, again, was the only lesion identified on this patient's whole bone study. So, what happens to these patients when they're treated? The marrow signal is going to resolve, and the edema is also going to resolve. This is a 16-year-old who had knee pain, and we can see some patchy marrow signal here in this proximal tibial metaphysis corresponding to this edema on our fluid sensitive sequences. A year follow up after treatment, we can see that this marrow signal is now almost identical to what we're seeing in the adjacent epiphysis. So, typical normal fatty marrow signal. There is no persistent edema on our fluid sensitive sequences. Another thing that's important to think about with CRMO is to think about what the post treatment changes that we see in these patients are when they've been treated with specific therapies. Bisphosphonates have a specific radiographic appearance following treatment that we may see in several of these patients. These can demonstrate very sclerotic metaphyseal bands. In patients who have intermittent treatment, these bands can be discontinuous. So we see here the MR of a patient and the radiograph of a patient who had intermittent bisphosphonate treatment. You can see this kind of discontinuous areas of these darker signal in the metaphysis, one here, one here. A little bit more difficult to see on our fluid sensitive sequences. But when we go to our radiographs, I think it's most apparent here. We can see just adjacent to the metaphysis, a band here, a few more bands here. And we even see this along our iliac crest right here. And these are bands that occurred during the bisphosphonate use. For patients who get continuous bisphosphonate treatment, they will have thicker and denser bands, and these are most apparent at the sites of rapid growth in these patients. So we typically see these around the knees and around the wrists. This is an MR of the knee in a patient who received continuous bisphosphonate therapy, and we see this very broad area of low signal at the physis, both in the femur and at the tibia. We see that this has high signal on T2 weighted sequences. And on our radiographs, we can see at this area in the wrist where we have very rapid growth, a very thick band of dense sclerosis compatible with a patient who's been receiving continuous bisphosphonate therapy. We're going to move on now and speak a little bit about Langerhans cell histiocytosis and the typical osseous findings that we can talk about here. And there are several that we see in these patients. In the skull, we talk about seeing punched out lesions, a beveled edge on a lesion, and coalescing lesions within the skull to give almost a geographic appearance. In the spine, vertebra plana is one of the things that we talk about. I know we discussed this in CRMO as well, but this is also something that we see in Langerhans cell histiocytosis and is one of the classic findings that we think of here. In long bones, we can have diaphyseal or metaphyseal lesions, but these lesions can be anywhere. This has a very diverse appearance. We may see endosteal scalloping and cortical thinning. You can have a soft tissue mass with these lesions, and these can appear very aggressive. In some of the flat bones, like the scapula, we may see lytic lesions with sclerotic margins. But Langerhans cell histiocytosis is one of the bone lesions that, for us in radiology, really comes up very frequently when we're talking about a lucent lesion, because this can have such a large variety of appearances and can be seen in so many different ways. But we're going to talk a little bit about our typical lesions. So, this is a typical lesion in a very typical location. This was a 5-year-old with a scalp mass. And we can see on the lateral and coronal radiographs, we see these multiple areas of lucency within the skull, anteriorly here within the frontal bone, posteriorly here within the parietal bone. On the frontal image, we can see all of these lesions. They almost look like they're coalescing together. This is very geographic. On these lateral images, we almost see that slight beveled edge appearance with the skull, which we can make out as well on our CT right here, where we see the beveled edge on the skull with the adjacent soft tissue mass. An MR demonstrates the calvarium here with this soft tissue mass that is replacing a portion of the calvarium with some deformity of the underlying intracranial structures. This is a very compatible appearance with Langerhans cell histiocytosis in these patients. The spine lesions that we typically see can be very similar to what we see in chronic recurrent multifocal osteomyelitis. The images on the left are from a 3-year-old with back pain with this vertebral height loss and end plate deformity of the L3 vertebral body. On our T1 weighted image, we can see this deformity, not a lot of abnormal marrow signal, maybe a little bit lower signal in this vertebral body, but less pronounced than some of the others that we saw before. But by 6-month follow-up, we have almost a complete vertebral plana here with this little wafer of sclerosis here and just this tiny vertebral body here that we're seeing between the disc spaces. By 12 years old, the patient was far out from treatment, and we can see that there was some improvement in the height of this vertebral body with pretty significant underlying shortening and end plate irregularity. When we talk about long bone lesions, this can be one of our most difficult types of lesions to identify. This can be very nonspecific and very similar to a large number of other long bone lesions that we see. But in this patient on the left, who's a 9-year-old who had a history of skull Langerhans cell histiocytosis, this patient complained of leg pain. And because we're sort of primed to that history, we can see here that there's this vague area of lucency with endosteal scalloping right next to my marker. On the lateral view of the leg, I think this is a bit more difficult to see, but you may get a sense that there is just some vague medullary lucency here, and this was a lesion. This is another image that we see from a 6-year-old with hip pain. We see this lesion. Not a lot of periosteal reaction that looks aggressive, but we can see that this is somewhat irregular, some cortical thinning here, especially at the margin. On our CT images, there's almost cortical breakthrough at portions of this and a suggestion of a soft tissue mass. This is another Langerhans cell histiocytosis lesion. And with this lesion, there was concern for possibly a more aggressive process in this patient. These are obviously going to be biopsied. Flat bones can also be a very difficult place to look for Langerhans cell histiocytosis lesions. The images on the left of the screen are from a 16-year-old with hip pain. On his x rays, it's hard to see whether there is an abnormality here. I think people really weren't suggesting too much before this. Maybe the lucent lesion we're seeing is here, but some of these areas adjacent to the acetabulum, which are shown to be abnormal in MR, look a little bit more typical on our plain film. When we get to our T1 and our T2 weighted images on MR, we can see that we have diffuse marrow replacement here within the acetabulum with surrounding edema and hyperintensity within this lesion. There's nothing specific about this. This was biopsied and found to be LCH. In this patient with shoulder pain, we have post-contrast images demonstrating a mass within the glenoid fossa right here and the scapula. And we can see here that there's soft tissue breaking out of the scapula posteriorly with disruption of the cortex as we see it posteriorly here. The last thing that I'm going to talk about today is some of the other pathology that we consider for these patients. Because when we talk about LCH and CRMO, we do see a lot of patients who may come with a concern for these lesions, but have other diseases. And I just want to go over some of these things and how we think about this as well. Several neoplastic disorders may mimic these conditions. One that we're very concerned about always is sarcoma. And things like Ewing sarcoma can certainly mimic these lesions, and the location can be very confusing for these patients. This was a 16-year-old who presented with shoulder pain and a specific palpable mass in the region of the clavicle. The image from this patient when we did the ultrasound is right here, and you can see there looks like a very pronounced soft tissue mass in the region of the clavicle. And this could look very similar to several of the people with CRMO. When we went to do the ultrasound for this, however, we can see that there is primarily a large soft tissue mass surrounding the clavicle here, which we see shadowing down here. And when we look at this soft tissue mass, we see these bright white spikes going out to the soft tissue mass, which is an aggressive hair on end periosteal reaction that we're seeing from the clavicle extending into the soft tissue mass. On our radiograph here, you can faintly visualize part of that periosteal reaction, but it's very difficult. When we go on to the MR here, we can see on our fluid sensitive sequence that there is this fluid sensitive mass surrounding the clavicle with post contrast enhancement, almost with that spiky periosteal reaction appearance. And this was compatible with a Ewing sarcoma. But in other clinical settings, something like this could be very similar to what we would be seeing in a patient with CRMO. Leukemia can also be a mimic for these lesions. Oftentimes, patients may have systemic symptoms or vague multifocal pain. This is a patient who came in with back pain, leg pain, and fatigue. And on her chest x ray that she got, I think just for the fatigue and just for, well, is there anything going on? We see immediately on the lateral view of her spine from this chest x ray, we can see first that there's diffuse osteopenia. These bones don't look very dense. And when we look at the vertebral bodies, we see that there's height loss within several of these mid thoracic vertebral bodies. I think it's even probably more than the ones that we're initially identifying here that are most apparent with clear end plate abnormalities. This patient went on to have an MR because of these leg pain and fatigue issues. And we can see here within this femur that for a patient who's 5 years old, the marrow signal diffusely is a little bit darker than what we would see in some of these areas, like this proximal epiphysis here, where we should really see very bright fatty marrow. It's a little bit more intermediate. This is very patchy within our diaphysis. There are areas of high T2 signal and post contrast enhancement within this. And this is a patient who had leukemia and was presenting in this multisystemic way with just very generalized symptoms. Bone lymphoma is another thing that we have to think about in these patients. Oftentimes, we may be seeing this in some of the older patients. The images on the left of the screen are from a 16-year-old with known Burkitt's lymphoma, where we see on an MR, on T1 weighted images, fluid sensitive sequences, and post contrast images, we can see that there's this area of dark marrow replacement with adjacent edema and post contrast enhancement. This is just a very geographic lesion that we're seeing here on this MR. And this is not specific for any entity, but in the setting of his Burkitt's lymphoma, this was something that we suspected. The images on the right of the screen are from a 16-year-old with chest pain. In this patient, we can see on CT images that there is this abnormality within the chest wall, a rib lesion with a very large soft tissue mass here and destruction of the rib. It's hard to really say what this is going to be. We'd be very concerned that this is an aggressive lesion. We certainly would be thinking about a Ewing sarcoma or any of the entities that we were talking about. Could this be an LCH or something else? Potentially. But when we go and we finish this CT and we look into the abdomen, we can also see that there's this vague lesion here within the body of the pancreas. So this patient went on to have a PET CT afterwards, and we can see that on our PET images, we have uptake both in the rib lesion and in the pancreas lesion. This is multifocal disease, and certainly one of the thoughts would be, could this be a sarcoma that has metastasized? We often will see pancreatic metastases with sarcoma, but this was a patient who had a diffuse B-cell lymphoma, primarily involving the bone, but also with multifocal disease. Metastatic disease, especially metastatic disease from neuroblastoma, is one of the other entities that we can think about, especially in patients who may present with a palpable scalp finding. So, this was a 2-year-old who had palpable scalp masses. These images from the MR that they received show first this expansion of the marrow structures surrounding the orbit medially with a soft tissue mass. We also see this large soft tissue mass posteriorly involving the calvarium. When we go a little bit higher in the scalp, we can see an additional soft tissue mass here with disruption of the calvarium, as well as a mass here. These are multifocal masses in this patient. This patient then went on to have a CT scan where we identified within the suprarenal fossa on the left and extending into the mesentery, we see this very large soft tissue mass here with multiple calcifications. This is stretching and compressing multiple vessels that we see here through the mesentery. And this is a very typical appearance for neuroblastoma. When we look at our CT images of the spine on the right side of the image, we can see both the calcifications here anteriorly from the primary neuroblastoma, as well as all of these vertebral bodies, several which have sclerosis and height loss, others which just have more focal areas of sclerosis. And the images on the bottom left of the screen we see are from an MIBG scan where we give the patient a norepinephrine analog. This radiotracer goes to neuroendocrine tumors, including neuroblastoma, and we can see that there's diffuse involvement really of the skull and all of these osseous structures here, bones surrounding the orbit, the bilateral humeri and ribs. None of these structures should have uptake of this radiotracer unless they have metastatic disease. This image of the abdomen and pelvis shows the significant uptake in the primary tumor, as well as all the bone uptake throughout the pelvis and the legs. Another thing that we need to consider in these patients is there a possibility that a patient has a multifocal bacterial infection and not a non-infectious osteomyelitis? This is a patient who came in and presented with shoulder pain, back pain, and leg pain. Imaging of their shoulder here on an MR showed us on T1 weighted imaging, we can see that there's this marrow replacement within this proximal humeral metaphysis. On the post-contrast images, we can see that there's a suggestion right here, right where my cursor is going, of a subperiosteal abscess here, which is something that we may see a little bit more commonly when we're seeing infectious osteomyelitis and a lot of inflammatory changes in the adjacent soft tissue. The patient then was complaining about other sites of pain. When we went down and we did an MR on his legs, we can see on these fluid sensitive sequences multiple T2 hyperintense lesions throughout the hamstrings and the quadriceps muscles bilaterally. These were all small abscesses. This patient then went on to get an MR spine for the back pain, and we could see here that there is this abscess within the paraspinous muscles on the left side. And this was really just starting with an osteomyelitis with the proximal humerus that then seeded to multiple other sites. And a final thing that we just want to remember and think about in these patients are there possible orthopedic abnormalities that are underlying their problems? This is a patient who came for possible foot pain and swelling. We were concerned about either arthritis or osteomyelitis. When we look at the image of this patient here, we can see the calcaneus and the navicular here look very narrow with this kind of irregular and fragmented area right here at this joint. When we go to the MR, there was a lot of motion here, but we can see that there is edema centered here at this calcaneonavicular joint and post-contrast enhancement centered right here. And this is a patient who has a calcaneonavicular coalition, also has pes planus and some pain there. And this was felt to be the main cause of his foot pain at the time being. Thank you so much for your attention today, and I look forward to answering any questions during the roundtable session. Thank you.
Our next speaker is Polly Ferguson, a world-renowned expert in chronic non-infectious osteomyelitis. Dr. Ferguson is a pediatric rheumatologist at the University of Iowa. She is a professor of pediatrics and the division director of pediatric rheumatology, allergy, and immunology, and the executive vice chair of the Steed Family Department of Pediatrics. Dr. Ferguson's research interests include genetic aspects of inflammatory disorders, and her current research projects focus on determining the genetic basis of chronic recurrent multifocal osteomyelitis, Sapho syndrome, and lupus. Thank you, Dr. Ferguson.
I want to thank you guys for your invitation to talk about autoinflammatory disease of the bone. I'm going to focus predominantly on chronic recurrent multifocal osteomyelitis, but also talk about syndromic forms of the disease as well. These are disclosures that all the medications are going to be used off-label. There really is no FDA-approved medication for use in CRMO. And these are funding sources that have helped to fund the research that I'm going to show towards the end of the talk. So chronic recurrent multifocal osteomyelitis or chronic non-bacterial osteomyelitis, you've heard about this morning already, but just as a concise kind of summary, it's an autoinflammatory disease. At least that's what the research shows to date. Predominantly affects children, but can affect adults. There's more females than males. As kids present with bone pain, some of them have fever, but that's the minority. And the vast majority present with multifocal osteomyelitis. And that's why the term CRMO has been the name for many decades. However, some do present with a single bone lesion. And so the term CNO, or chronic non-bacterial osteomyelitis, encompasses those patients that only have one bone lesion. The bulk of them have recurrent disease, although some have chronic disease and some have one episode, and that's it. X-rays, this is kind of a quintessential X-ray of CRMO. You see osteolytic lesions surrounded by sclerosis. You can see them here in the distal tibia, in the distal fibula, as well as other bones. They usually abut the growth plate, and cultures are uniformly negative, except for in adult Sappho syndrome, which we won't talk about. And there's typically no response or a minimal response to antibiotics. There's a lot of aliases, which makes looking through the literature and doing searches and doing research difficult. The main terms that are used now are chronic recurrent multifocal osteomyelitis, CRMO, or CNO, as we talked about. The adult rheumatologist seeing the same phenotypic features would call a patient Sappho syndrome. So synovitis, acne, pustulosis, hyperostosis, and osteitis syndrome. And then depending on what specialty you are, there's all sorts of different names for it. And really, these are all look to be the same phenotype, just with different names. These images show the clavicle, which is something that's should be an alarm bell that it could be a CNO, because not very many things cause osteomyelitis of the clavicle, particularly in someone who doesn't have any, like a central line or any sort of hardware in their body. So here's a child that has bilateral clavicle involvement, but when you do a whole body MRI, you can see that they have long bone involvement also, which helps make the diagnosis. And it's very important to recognize the associated inflammatory conditions with this. Palmar-plantar pustulosis, up to 30% in some older studies, but when you're looking at large cohorts, it's more around 10%. Psoriasis vulgaris, or any form of psoriasis, really up to 20%. Intestinal inflammation is common, so 10% will have Crohn's disease, more so than ulcerative colitis. And then we have some patients who have celiac as well. And then Sweet syndrome, congenital dyserythropoietic anemia, generalized pustulosis, severe acne, inflammatory arthritis away from a bone lesion have all been reported. And over time, some centers have reported that some of these kids go on to look like a spondyloarthropathy and have more axial spine disease. Less common associations are Still's disease, Takayasu's arteritis, ANCA-positive vasculitis, juvenile dermatomyositis, ocular inflammation. And I'm going to talk to you about a new paper that shows that maybe the lungs are involved as well. So here's an example of palmar-plantar pustulosis. It can be a bit hard to diagnose. A lot of people, if they make a mistake, will call it dyshydrotic eczema, but you can see it's actually pustular. Here on the foot, there's a new pustule, and then you can see all sorts of pustules in various stages of healing. And if you look histologically, there's just a lot of neutrophils in this skin here. Bad, severe cystic acne is also something that happens. And this is seen more in the adult realm. When kids have CRMO, the average age of onset is about 9 or 10. Most of them don't have the hormonal milieu to have bad acne. So I've had a fair number of my patients develop the acne when they're older teenagers or young adults. And then any form of psoriasis, with palmar-plantar pustulosis being the most common, but also plaque psoriasis. That can be guttate psoriasis, nail psoriasis without skin manifestations, any form of psoriasis I've seen. Inflammatory bowel disease. This is the original case report of a patient with osteitis in their hand who had ulcerative colitis. This is a patient of mine who has multifocal osteomyelitis here involving the skull, which is unusual, but also the pelvis. And she had a lot of bowel issues, and she ended up having celiac disease. Interestingly, later, her sister developed CNO involving the clavicle and did not have celiac disease. And for this patient who did have celiac disease, a gluten-free diet did not heal the bone lesions. This is the newer thing that I want to talk about, is pulmonary disease and CNO. And I think this is an evolving story, but really one that's been going on for a while. So in 1989, this was Ron Laxer's group, reported a patient with CNO that had pulmonary lesions. And then Angelo Rovelli in 1995, also a patient that had pulmonary lesions. And then Winstone et al., here's another with these they look kind of like fungal infections, I would say, more than anything, but nodules in the lungs. And in 2025, Hryhorczuk et al., predominantly German cohort of nearly 800 patients with CNO, they found that 2.8% of their patients had pulmonary involvement. So I think this is something that we need to pay more attention to. Here are some cases that I've had recently at Iowa. This isn't all of them. Here's the patient again with those similar nodules to what you saw in the prior slide. Again here, another patient. This patient had these surgically resected, and they showed granulomatous inflammation and grew a fungal infection, which we're not 100% sure isn't a contaminant, but they went on antifungals. This patient was completely well, and these lesions were found incidentally on whole body MRI, followed up with a CT scan of the chest, and without any treatment whatsoever. And this happened without being on a TNF inhibitor. This patient with these lung nodules, they have subsequently started to resolve. So this lesion now still present, but much smaller. So not sure yet what these are. There aren't very many of them that have been biopsied. And they're kind of difficult to see on whole body MRI. So I think our radiologists have to start looking a little closer at the lungs to see if there's any sign of these nodules, and then to get a CT scan for those who there is suspicion. So what do you do to work these kids up? It's really difficult. The labs really don't help very much. So these patients can have a normal white count to mildly increased white count, normal to mildly to very elevated sed rate or CRP. And it seems that different cohorts have different degree of inflammatory marker elevation, where Sarah Stern's cohort at Utah tends to have very high sed rates and CRPs, whereas the cohort I see is pretty mixed from completely normal to those that have a high sed rate CRP. I would say that if somebody has a sed rate approaching 100, I always look for inflammatory bowel disease just to make sure, or a form of vasculitis or something else that might be driving that sed rate. For the differential diagnosis, I get vitamin C and vitamin D levels to look for scurvy and rickets, alkaline phosphatase that helps you get hypophosphatasia off of the differential diagnosis. These patients can have multifocal bone lesions and not have CNO. They can be a mimic for leukemia, lymphoma. And so I do uric acid LDH. And for those that I'm concerned might have a malignancy, really push for getting biopsies. Sometimes they require multiple biopsies to catch the malignancy. So biopsies with cultures, usually if it's early on, it will show a lot of neutrophil and acute inflammation. But if you biopsy them later in their course, then there's more sclerosis and a mixed inflammatory infiltrate. This biopsy here shows more acute inflammation. In plain films, like we showed earlier, osteolytic lesions with surrounding sclerosis involving the long bones, the clavicle, spine, pelvis, mandible can all be involved. The small bones of the hands and feet can as well, but that's less common. And then whole body imaging, as you heard about earlier, has just been an essential tool. I just wanted to show everyone here that you can do the whole body MRI in a pretty limited amount of time, so it can be very fast. Our protocol is a stir-only protocol. We don't use it for the first diagnosis. So at diagnosis, the most painful spot will get a full sequence MRI, but subsequently, if we want to whole body image, we will do stir only. And as you can see, these are the planes that we use and the acquisition times for each of those. Total scan time is less than 25 minutes, sometimes 30 minutes if we have a really tall patient. But it can usually be done in one MRI slot, and hardly anyone needs sedation. So imaging, really important. A lot of these lesions that you'll see on MRI and on plain film are asymptomatic. And that is one of the reasons why whole body MRI is really essential to making a diagnosis. For example, in this plain film here, you can see a distal fibular lesion, and it doesn't look very impressive. I would say there is a look of sclerosis and then this osteolytic area here. But if you look at MRI, it's really obvious on stir images that there's inflammation there and an abnormality. And then this just shows clavicle again, showing how important it is that we look at those clavicles. And these patients with clavicular involvement are very much likely to have CNO, although Ewing sarcoma can present here. So it's not 100%, but it's very pathognomonic for CNO. So as I talked about with the labs, the differential diagnosis, a lot of these kids will have a diagnosis of growing pains for a long time, which delays their diagnosis. I would say one of the differentials with the growing pains is that usually growing pains are bilateral legs. And in CNO, usually they will have one very painful spot, more so in one leg than the other. And so that is just something that if you have asymmetric pain, not to define it as growing pains until you've really done some investigation. Infectious osteomyelitis is the main differential diagnosis. Here in CNO, low inflammatory markers should make us think of sterile inflammation, and then the whole body MRI can be very helpful to get what might look like a staph osteo, and then you find out, oh, there's 10 other lesions that make staph osteo less likely. Malignancy, as I talked about earlier, Ewing sarcoma, lymphoma, leukemia. This is a patient here that has had an interosseous lymphoma. And so I just wanted to show you some danger signals on plain films. So this is an osteolytic lesion without sclerosis. So that always makes me very concerned that it's something else. And then here it's hard to see, but this lesion has broken the cortex. So anything that breaks the cortex should also just have you have a high suspicion that it's not CNO and look harder and do the biopsies. Any histiocytic disorder like Langerhans cell histiocytosis, hypophosphatasia. Not often do we get people misdiagnosed with fibrous dysplasia, but sometimes. We've seen patients with primary immune deficiency who have immune dysregulation presenting with sterile osteomyelitis. Scurvy, more and more, we've seen quite a bit of scurvy, and they're almost all a child on an autism spectrum disorder that has really restricted food intake, so just a limited number of foods and hardly ever any fruits and vegetables. And then I'll talk about syndromic forms of CRMO coming up. This patient here ended up having Langerhans cell histiocytosis. So what are our treatment goals? Really to relieve their pain and suffering, to prevent them from having long-term damage. Here is a spine that's involved. You can see multiple vertebral body levels that have compression deformities. This one has slightly high signal, but this is more damage rather than active disease at this point. We want them to be able to heal and remodel. Some backs will recover some vertebral body height, but most don't. And then physical therapy and treatment can help them regain function they've lost. And then treatment must really account for comorbid conditions. So if somebody has psoriasis or Crohn's disease, we're going to pick different medicines based on that, which are going to help bone and skin or gut. This is a patient who has palmar-plantar pustulosis, pretty mild on her hands, but pretty significant on her feet. And this was her more than complaining of bone pain. It was this rash on her heel that was the biggest problem. But she limped when she came to see me, and she had a pelvic lesion. She also had long bone lesions. So treatment options right now, like I said, it's all really empiric. There's no FDA-approved medication. And so it makes it a little bit difficult to know what the best treatment is. So you go to the literature, and there are a few prospective trials, one for nonsteroidals, which I'll go over in a minute, and a couple prospective trials on bisphosphonates, but very small numbers. There's reports of successful treatment with corticosteroids, non-biologic DMARDs such as methotrexate and sulfasalazine, cytokine blockers, predominantly TNF inhibition, but also some IL-1 blockade, bisphosphonates. There's mostly in the literature use of pamidronate, but also zoledronic acid. And then surgical intervention is reported in the literature where a surgeon might decorticate the whole lesion, but this is rarely necessary. And is increasingly avoided since medical management has become pretty successful here. So this is a nonsteroidal anti-inflammatory drug and prospective open label trial. Beck et al. Performed this in the early 2000s, actually 2012. It was relatively small, so there's 37 patients. They used naproxen, 15 milligrams per kilogram per day divided, and they did this for the first year of disease. 43% reported complete resolution of their symptoms, but that means 57% didn't. So less than half had complete resolution. They counted radiologic lesions, which is probably a bit of an underestimate because not everybody had a whole body MRI, but they originally had 184 bone lesions in this cohort, and at a year they were down to 81. And about 10% had to switch due to no response. So their protocol was to switch to sulfasalazine for those who had no response to NSAIDs. There's a couple of prospective bisphosphonate studies. So this one was 9 individuals, open label, and they got monthly or the 3 days in a row every 3 months from pamidronate protocol. And they had an MRI at baseline and then after their second treatment. They continued to use bisphosphonates until the bone lesions resolved. So it was a radiologic endpoint. They retreated if they flared. And those who flared, 5 developed recurrence of pain 12 to 18 months after their first pamidronate. 4 of 4 flares received 1 infusion to treat their flare, and that 1 infusion resulted in resolution of their pain. And the average at 6 months was to have greater than 90% MRI improvement. So at 6 months, most had improvement. So it looked pretty promising. The other prospective bisphosphonate trial was very small. So it was double blinded, but there were only 12 participants, which is pretty small to have enough power to detect a difference. And they did see radiologic disease activity scores in the anterior chest wall decrease and pain increased, but not statistically significant. So we have this problem with not knowing exactly what the best treatment is. And if you ask physicians across different areas of the world treating these patients, there's a huge amount of variability in treatment. So this is treatment of over 1,000 patients, predominantly in Europe, but there's also a Canadian cohort and a US cohort in here. So some North American patients, and most were using NSAID. So 92% got a nonsteroidal, 10% plus got sulfasalazine. There was a quarter of the patients who were treated with glucocorticoids, bisphosphonates in about 15%, not as many TNF inhibitors, almost 8% here, methotrexate 17%, and then a lot of them got antibiotics prior. If you ask physicians predominantly in North America, the Care Physician group on CNO, which is mostly North American, but there are others, including a fairly sizable group in Europe that are in the CNO Care group. And you ask, what is their choice for second-line treatment? We didn't ask first-line treatment because nearly everyone chooses an NSAID unless there's spine involvement. So choice of second-line treatment, what you saw was 67% would pick methotrexate. Nearly the same amount, 65% would pick a TNF inhibitor. And sometimes these are used together, but not all the time. And then a bisphosphonate of 46%, corticosteroids in 29%, and 21% use sulfasalazine. Why did people pick a nonsteroidal as first-line treatment? So here, some of them went on, about 10% would use something else as first-line treatment. And the reasons were pathologic fracture, typically in the vertebral bodies, a damaged physis, concerning for the development of a bony bar. Some people don't go with NSAIDs alone when there's a mandible, cranium, pelvis, or clavicle involved, but some do. So now here's some response data. So this is response to treatment, 3 tertiary care centers. And what we see here is a lot of these kids get antibiotics prior to determining that this is sterile osteomyelitis. They're completely ineffective at about 75% and partially in about 20%. I think one of the things that's really important to realize is that antibiotics, almost all of them, have some anti-inflammatory effects that are separate from their antimicrobial effects. So it's not surprising that there's some inflammatory relief with the use of antibiotics, but by and large, the clinical remission is very small, And if somebody completely improved with just antibiotics alone, I would probably not continue to call them CRMO or CNO. Then if you look at NSAIDs alone in this group, quite a number. It's about the same as that Beck group that I showed you earlier. Almost the same, it looks like 45-ish% completely ineffective. And then about the same amount only partially effective. So a very small group gets clinical remission, which probably is telling us we might be under-treating a lot of patients. And then this is sulfasalazine and methotrexate. So again, not very many in this complete clinical remission. The highest with clinical remission was with a TNF inhibitor and followed by corticosteroids. Of note, there's no bisphosphonates use in this group. So here's a Dresden cohort, and they had more bisphosphonates and TNF inhibitors. Use was minimized here because their insurance algorithm was that it had to go bisphosphonate first. So NSAIDs, only about 50% had clinical remission completely at 24 months. Corticosteroids, at 24 months, 40% had complete clinical remission. TNF inhibitors, you'll have to remember this is a very small group, but 67%. And then bisphosphonates, 83%. This is a nice study also in a German cohort where they basically took bisphosphonate and TNF therapy, and they looked at those patients who were treated with one or the other from 2002 to 2020, and they were either in England, Scotland, or in Germany. And this is the number from each country. They had 126 patients that had CNO, and they had to exclude 35 because either they didn't get treated with a bisphosphonate or a TNF inhibitor, uncertain diagnosis, or they got treated at the same time with them. So they were down to 91 patients. And what they looked at was who got pamidronate, who got TNF only. That's this group and this group. 47 got only pamidronate, 22 got only a TNF inhibitor. And then there were 22 patients that had to switch. And so because they failed. So one of the things to notice is that there were more failures in the pamidronate group than in the TNF group. And then if you looked at those that did have to switch, so the TNF inhibitor group to pamidronate group, and this is time to failure. So this is the fact that this is up higher is actually worse outcome. So what it showed was that if you had to switch and you switched to a TNF inhibitor, they tended to do better. And also that there were less people that had to switch from a TNF inhibitor to a bisphosphonate. So this suggests there's more treatment failures with pamidronate than a TNF inhibitor. But again, it's not a prospective blinded trial. So how can we do more analysis of what's the best? So we've been trying to find a pharmaceutical company who would fund a placebo-controlled double-blind study, but we have not. So how could you do this without having a lot of money? And one of the ways is to do a comparative effectiveness trial, which is similar really to what was done in the prior slide. And this is a CTP that the CARE group came up with, so both national and international group. And what they said was, if you had CNO refractory to an NSAID, what would your treatment plans be? So there was 3 treatment plans that people agreed upon. Treatment plan A was to use a non-biologic DMARD alone, either methotrexate or sulfasalazine. Treatment plan B was to use a TNF inhibitor, and some use methotrexate with that to help prevent antibody formation against the drug, which is what we do in our clinic when we use a TNF inhibitor. And plan C was to use a bisphosphonate. And so what would happen is you would get every 3-month follow-up visits, and you would determine if you were improved or unchanged or worsened. And if you improved, then you would follow your plan. And if you worsened, then you could change plans to another treatment plan. And then we collect all the data the same way, and you could try to see which group did better. So that we don't have the answer to, but is an established plan that we now can utilize to try to determine which is better. Should we use a TNF inhibitor Should we use a bisphosphonate? Are we keeping too many kids on nonsteroidal anti-inflammatories too long? All these questions need to be answered. But one of the problems is like, how do we measure success? Pain really is the most important thing to the patients and parents. They really want their kids to be pain-free. But this is complicated by the development of secondary pain syndromes. A lot of these children with CRMO are diagnosed very late, and a fair number develop a pain syndrome, and they continue to have pain even when their MRI is completely normal again. So this makes pain as the primary outcome a little bit difficult, because if you have a pain syndrome, you're still going to be in pain even though the treatment seems to have worked on the inflammatory bone lesions. And then imaging. So imaging is, to me, essential to determining if somebody's improved or not. So how much pain they have, do they have a swollen area overlying a bone? So clinical outcomes, but also imaging. And then we have this question, how do you score an MRI? Different centers score it different. Are they reproducible? How doable is it if we have a protocol for scoring every single bone lesion? What if you have 20? That might be too much for the radiologist to do and to want to do for a study. So that is also being worked on, and we're getting to the point where there's agreement with how to score them and also good reproducibility. So labs aren't super helpful. Most of them are normal for a lot of patients are so minimally elevated that there's not a lot of room for improvement. So they don't help a lot in showing that a therapy was effective. A lot of people want to use a CHAC, but a lot of those questions are upper extremity focused. So they're more helpful for like juvenile arthritis when CNO is really primary lower extremity. So again, it just limits the amount of items in the CHAC that can actually change. There's a CNO score that was developed by Hryhorczuk in the German cohort, which is pretty interesting and is very promising. And then there's now a group that's putting together composite clinical disease activity score that will then be validated and be able to be utilized. And then also there are different CNO specific registries. The Choir registry, Dan Zhao has developed, and a lot of people both in the US, Canada, and abroad are able to use this registry, which is more specific for CNO rather than just an autoinflammatory registry that isn't specific for bone. And then there's an OMERACT group that is really trying to work on coming up with a CDS or a clinical disease activity score that can be used in clinical trials. So what happens to these kids? Their variable outcome. This is a patient that I took care of for a long time, well into her adulthood. So I think the last time I saw her was more in the pre-pandemic arena. So here she was when she presented. She had this osteolytic lesion in her long bone. This is her distal femur. And over time, you can see it with treatment, it began to heal and really remodeled. She did end up with a fairly significant femoral bowing and bony overgrowth from this bone growing more than the other leg due to all this inflammation that wasn't present on the other side. So what happens in the long run? We don't have a lot of long-term great data. The Choir registry will help, I think, with that. But there's variable responses from everybody doing well after 5 years or more in follow-up, or 100% of them not doing well. And there's real bias in how you do long-term follow-up studies because individuals who aren't doing well tend not to come back to the doctor. So they're kind of lost to follow-up, which can make it look like the outcomes are worse than they actually are. What we really need to do is follow prospectively a cohort and try to keep everybody in the cohort, even those that are doing well. Vertebral body involvement occurs in about 25%. And this is the one area that is most likely to cause long-term damage. And a lot of people would use bisphosphonates if there is vertebral body involvement, just because it rapidly shifts bone metabolism towards bone building rather than bone destruction. So pathologic fractures, kyphosis, and scoliosis can occur. These compression deformities up to 40% in some studies, but when you look at a lot of different cohort studies, it's probably around 25% with with back involvement. You can develop a physeal bar, which is shown here, a leg length discrepancy, which I just talked to you about, angulation, which I just talked to you about, and then hyperostosis. When you get really, a bone is very hyperostotic, and it happens to the clavicle a lot. It really takes quite a long time for that to completely remodel, if it ever does. The jaw also does that. So then we have, it looks like maybe TNF inhibitors are the way to go over bisphosphonates, although I would say that that needs to be done in a more rigorous clinical trial. But seems to be a problem with TNF inhibitors and CNO. So some children are developing TNF inhibitor associated with psoriasis. We all know that can happen. It can happen in JIA, it can happen in Crohn's disease, really any disease in which a TNF inhibitor is used. So if you look at kids on a TNF inhibitor who have CNO, inflammatory bowel disease, mostly Crohn's disease or JIA, and then you look to see how many of them get TNF-associated psoriasis, it is more common in the CNO group. So this was a group where they looked at 1,000 patients that met inclusion criteria of being on a TNF inhibitor who had one of these three disorders. And what they found was there was psoriasis after exposure to TNF inhibitors in 31 patients. And when you looked at who had the most, this was in CNO patients, had more of it than others. The scalp was involved in 84% plaque psoriasis and 88%. And so this was 14 out of 28 CNO patients, 3 out of 621 JIA patients, 25 out of 450 IBD patients. So quite a bit more in the CNO patients. And then suggesting that CNO is more likely to have this happen rather than in these others. Another study that was at Seattle, this is at CHOP, and so this was bigger, so nearly 4,000 kids met criteria. And then they did incident rates of TNF-associated psoriasis. And as you can see, it was twice that of JIA and nearly 3 times that of IBD, so suggesting increased risk in underlying CNO. And then what do you do if this occurs? It can be really quite bad. There's a lot of kids who have a lot of alopecia with it, so lose a ton of hair. So stop the TNF inhibitor. If it's mild disease, use topicals. Get your dermatologist involved. Phototherapy can help. Starting methotrexate can help. And then, really get guidance with your dermatologist. Dan Zhao has switched a lot of them to Simponi and had that be beneficial and tolerated, but I don't think we know what the best thing to do is. Our group hasn't seen it, I don't think, as much as others. We almost always use methotrexate with a TNF inhibitor to try to prevent the development of anti-drug antibodies, but perhaps that's providing some benefit. It also could be that we just haven't looked hard enough because we really haven't gone through all our data to look. But it's been a small number of children that I've taken care of that have had this happen. Here's one of my patients that it did. So this was near Halloween, and she had half of her hair bleached and the other half not. But what you can see is that she developed this area of psoriasis and did lose quite a bit of hair, which you can kind of see now has got all these small pieces as it's growing back in. She stopped her TNF inhibitor. She was on infliximab. Her bones became very painful. Mom decided that just to go back on the infliximab and deal with the hair in a different way. They took a vacation down to Florida, spent a couple of months in the sun, and her psoriasis resolved. She continued on the infliximab and didn't have that problem going forward. So what do we do with treatment-resistant patients? What if they don't respond to an NSAID, a TNF, or a bisphosphonate? Can we learn something from adults? Can we learn something from those patients who have a syndromic form of CRMO? There's been a handful of reports of using other cytokine blockers, IL-1 inhibitors, IL-17, IL-12/23, a few JAK inhibitors. I've used that in a few of my patients. I had one who had alopecia areata who went on a JAK inhibitor for that indication. Her bone pain got better. Her hair is growing back, but radiologically, she still has lesions. So that's pretty mixed. But those are usually patients who have failed everything. So they tend to be the more severe disease that go on to get these other agents tried. So what's the information about cytokine dysregulation in CRM-SAPHO? And there is information that they overproduce TNF, IL-6, IL-8, IL-18. And so there is cytokine dysregulation. The CRMO monocytes also produce less IL-10 and IL-19. There's some evidence of epigenetic changes done by Christian Hedrick's group, changes in methylation. So there's some interesting changes that affect our immune system, but we don't know exactly what is the best cytokine to block, and we don't have a good biomarker. What we do have some information about is from genetics. So there's evidence that this has a genetic component. There's reports of effective siblings, parent-child duos, who I'll tell you about one of them who we studied. And then we have found that 50% of first or second degree relatives have psoriasis or IBD or inflammatory arthritis like rheumatoid arthritis. There's animal models of disease, so HOD in dogs, murine models. This is the CMO mouse for chronic multifocal osteomyelitis. They get inflammation in their hind feet and their tails. They can get inflammation in their ears. The dogs, they can develop Crohn's disease and pustulosis. So really pretty good animal models. There's also reports of monkeys that have developed CRMO. And then there are human diseases that we have found that have a genetic etiology that have sterile bone inflammation, including Majeed syndrome, DIR, and then a non-syndromic CRMO in which we found mutations in FBLIM1 and FGR. So Majeed syndrome was the first syndromic form of CRMO where we found the gene. This is autosomal recessive. It's due to mutations in lipin-2 or LPIN2. They present with recurrent fevers, early onset CRMO, most but not all before the age of 2, congenital dyserythropoietic anemia, and then the earlier ones, there were a fair number who had Sweet syndrome, although that seems to be less and less as we find more patients with Majeed syndrome. This is Hassan Majeed, whom it's named after, and Hatem El-Shanti, my colleague, with whom I did these studies. So this is a picture of a child with Majeed syndrome who was treated with nonsteroidals, but really had severe CRMO to the point of contractures of the joints and was bedridden. This is a bone scan from a patient with CRMO showing increased uptake near the growth plates, like would be typical in non-syndromic CRMO. If you look at this child's bone marrow, there are these bi and tri-nucleated pronormoblasts. These are abnormal red cells that then get removed from the circulation, and patients with Majeed syndrome have this congenital dyserythropoietic anemia that can be severe to the point they need transfusions to being very mild. There is data that IL-1 blockade is effective in Majeed syndrome. So this is two brothers that both had Majeed syndrome. One is shown in red and one is shown in blue. And the patient in blue was the older sibling and the red was the younger one. This is SED rate over time. And what you can see is, well, they took steroids. They had some improvement in their sedimentation rate. They then got put on etanercept and both worsened. So a TNF inhibitor and they worsened. They were then put on an IL-1 inhibitor, in this case, anakinra, and they both got better. The mom just felt like she couldn't give these daily painful shots to these boys anymore. She stopped doing it. They flared. The oldest son then got put on canakinumab that blocks IL-1 beta specifically, and he got better. Subsequently, the younger boy as well, who also got better. And this was 2011, and the last update I got was maybe a year ago that they were both doing very well, continued on canakinumab. And this just shows radiologic improvement after 3 months post-initiation of IL-1 beta blockade. And then this is just another case showing that this was not just in this one family, but has also been reported in other patients with Majeed syndrome, started on the IL-1 receptor antagonist or anakinra and doing very well. And then also just to let you know that there's phenotypic variability in Majeed syndrome. So some cousins from a consanguineous family in India had this variant in their LPIN2 gene, causing a truncation mutation. Clinically, they had CRMO. The first affected child had pretty typical Majeed syndrome starting at a young age, failure to thrive, high SED rate, and had dyserythropoiesis, and had this cousin who was 13 years old who started at that age developing painful long bones and really looked like classic CRMO. He had pretty normal hemoglobin. It's a little low for a 13-year-old boy, but did not have the typical low MCV that you would see in Majeed syndrome. So both, I think, treated with IL-1 blockade. And then just to show you that it really looks like lipin-2, the protein that's affected in this, is really important in cholesterol metabolism. And so the cells that don't have this protein have low intracellular cholesterol. And what it happens is it makes this P2X7 receptor function abnormally in such a way that there's increased IL-1 beta. So it looks like this is an inflammasomopathy. So what's happening here is we have low intracellular cholesterol from the lack of lpin-2, and that causes this receptor to gate abnormally. And it basically kind of turns on that inflammasome, so it's constitutively on, and there's increased IL-1 beta production. So I told you that there were patients who have run-of-the-mill CRMO that have multiple family members involved in their family that have CNO. This is a mother and her daughter that both have CRMO. And we found that they had variants in the P2X7 receptor, which I just showed you in the former slide, can be gated so that it's perpetually on and activate the inflammasome. And that's what basically the work here in Christian Hedrick's lab showed, is that not only did these two patients have abnormal inflammasome activity, but when they sequenced 190 CNO patients, they found that there was changes in the production of IL-1 beta. So if you stimulate their cells with LPS or LPS plus ATP compared to controls, which are shown in the green, there's marked increase in IL-1 beta production and IL-18 production. Now, the next story for genetics is DIRA. So this is a project that I did collaboratively with Paul Dancy in Newfoundland, and then the group at the NIH led by Dr. Rafaela Goldbach-Mansky. So Paul found a patient who had these very unusual bone lesions, had bone inflammation, high inflammatory markers systemically, and really was struggling to find out what was going on. When he gave the child steroids, they got better, but not completely better. And he thought this looked most like an autoinflammatory disease, so gave the baby an IL-1 receptor antagonist and got completely better very quickly. So he called Rafaela and I pulled out some early onset CRMO DNA that we had, and they had some patients at the NIH who had had similar onset of disease, and basically found that there were these babies that had autosomal recessive mutations in the interleukin-1 receptor antagonist gene. So this gene encodes the protein that is the IL-1 receptor antagonist, which is what anakinra is. So basically, Dr. Dancy replaced the very protein that these babies were missing, and that's why they got completely better. And so this presents with neonatal onset multifocal osteitis. They kind of look like they have rickets, as they have this rib splaying, they have clavicle involvement, they have involvement of the long bones, and have this periostitis that's pretty remarkable, and get pustules on their skin that's variable from very mild to quite severe. And if you treat them with IL-1 blockade, they get better. If left untreated, most of them will die from systemic inflammatory response syndrome. So here is a picture of a baby with DIRA who's responded to one receptor antagonist. This is within a couple of weeks, where skin has gone from really quite irritated to healing, and this is just sloughing of the bad skin with good skin underneath. And here you can see these osteolytic lesions with surrounding sclerosis that then have completely healed several months later. And then there are one or two reports of individuals with PAPA syndrome, which is pyogenic arthritis, pyoderma gangrenosum, and acne. that have had bone inflammation, but that's the minority. Most of the time, this is more arthritis, skin, and gut in this way. They have autosomal dominant mutations in PSTPIP1, and treatment with anakinra does help them, although they're very difficult to treat. So let's go to IL-1 inhibition with CNO. This looks like if you have a syndromic form of CRMO, that IL-1 inhibition seems to be the way to go. But that's not what we do in regular run-of-the-mill CRMO. One reason I think is because giving the IL-1 receptor antagonist requires a daily shot, which is hard to get families to do. And secondly, there's a fair amount of data in the literature over several decades that TNF inhibitors and bisphosphonates help. So this is a group that failed NSAIDs and bisphosphonates. 6 females and 3 males. They had mild to severe disease. 8 of 9 of these had an elevated SED rate or CRP at baseline. There were 77 lesions at baseline. And they went on to treat this cohort with the IL-1 receptor antagonist, that daily injection, and the average follow-up was 1.7 years. So bone lesions, 42 resolved, 35 remain stable, but 20 new lesions in 7 out of the 9 patients. 5 of 9 had a physician global that became none to mild, and the SED rate and CRP really improved in all but 1. So clinically, they improved, but they still had bone lesions. So this is then treatment in biologics with adults. And what you'll see here is that there's a fair amount of patients who get TNF inhibitors, and their bone and joint response is quite high in the adults, whereas the skin response is lower. There's fewer patients who have gotten IL-1 inhibition, but here 86% improved. They don't have any skin inflammation. And then just a smattering of other biologics that people have used, which I think it's hard to know from all of these what to make of this, except for that there is some report of efficacy, whereas others look a little bit less promising. So this is my summary. Sterile osteomyelitis occurs due to dysregulation of innate immunity. It can affect the bone, the joints, and the skin. There really are no FDA-approved medications. NSAIDs is what most people start with, and about half of people improve substantially enough that they stay on NSAIDs the whole time. For those who don't, usually the next treatment is either a biologic with an anti-TNF, bisphosphonates, or really a non-biologic DMARD. For a lot of clinicians, that's what they go to. Some people use both if they have difficult disease to control. We've determined that sterile bone inflammation can be genetically driven, where you can see this in 2 mouse models. There is a dog model in Weimaraners specifically that get a very similar disease that seems to run in the breed and in litters. And then there's human syndromic forms, including Majeed syndrome and DIRA. The genes that have been implicated are lipin-2, IL-1 receptor antagonist, FBLIM1, PSTPIP2, and FGR, as well as the P2X7 receptor. And then IL-1 is a key cytokine in the single gene models of disease, but hasn't been well tested for its efficacy in non-syndromic CRMO. Delays in diagnosis are common, so it's very nice that we are trying to get the word out that this disease happens, how to best define and make a diagnosis so that we get these patients before they have damage and before they have developed pain sensitization. And radiologists are really our key players in helping with a timely diagnosis. And then I have lots of people to acknowledge. Foremost would be Ron Laxer, who's been my mentor since I started working on this in the early 2000s, and lots and lots and lots of people have been great collaborators. Thank you.
Hello, everyone. Thank you to our panelists, Dr. Hryhorczuk and Dr. Ferguson, for their excellent and informative talks. And thank you to all the attendees for joining us this morning. We will now move on to the live Q&A session for this morning. And I would like to invite the attendees to start with their questions for Dr. Hryhorczuk. And while you are typing your questions in the Q&A box, I'll start off with a couple of my own. My first question, Dr. Anastasia, thank you so much for your talk today. You had shown an MRI of CNO in the ankle in a 10-year-old with ankle pain. another MRI of CNO in the clavicle. Regarding the MRI findings in those two cases, would the MRI alone be enough to diagnose definitively that it's CNO in the current clinical setting, or would malignancy still be on the differential based off of what you saw on the MRI?
So I think it's difficult. And I think a lot of these are kind of one, to me, I think of it more as what we're going to sort of put our bets on this being. How much do we think this is really something concerning versus how much do we think that this is probably going to be okay? And I think in almost all of the cases that I showed, none of these people were just cleared or fully diagnosed on their MRs. I think almost all of them had biopsies. But for example, if we see someone like a clavicle where we're seeing more of the classic C um, NO findings versus the patient where we did the ultrasound of the clavicle and we saw all of that very sunburst periosteal reaction and many findings that were extremely concerning. I think it just kind of lets you sort of decide, are you going to kind of bet on this as something more benign, or is this something that we should really be accelerating kind of the workup for?
Perfect. And then just as kind of a similar kind of question, there was a case of like a sarcoma in the clavicle, and you had mentioned that there were abnormal ultrasound findings. Do you know, since ultrasounds are much easier to obtain on little children, is there any clinical utility in getting ultrasounds in CNO?
I think in a known patient with CNO, probably not. But in cases where we're not fully sure what is going on, where we don't know, could there be a joint effusion? Could there be something like a septic arthritis? I think that in those cases, it's very beneficial.
I had a question. When patients develop sclerotic bands, especially with continuous bisphosphonate use, is there a concern or does it have an impact on the overall growth height of the patient?
So I saw this question before and I looked this up. I don't see anything in the literature that this involves the height. I think this is something that we see in children because what is happening when they have the bisphosphonate use, there's a period of time where they have inhibited their osteoclast activity. So we just have kind of the band of sclerosis occurring at that area where they're laying down new bone for growth and there's no reabsorption or remodeling there. That's why it's continuous in the patients who have had the continuous therapy versus interrupted kind of growth arrest type of bands or growth, I shouldn't say arrest, I should say more like growth abnormality bands.
Looks like we have a question from the participants that they find that so dental or OMFS likes to obtain cone beam CT scans for mandibular imaging. Besides the radiation, do you view this versus MRI to be equal?
I think it depends. I think MR is going to be superior for looking at marrow signal and very subtle marrow replacement. We can't really assess marrow signal or if we have fatty marrow versus something that is marrow replaced or marrow proliferative, which we can on MR. If we're talking about looking for something where we have cortical changes in bone, I think that that is wholly appropriate. And I think that um, in many ways, radiation now is much less of a concern to us. But I think we favor MR often just because it shows us the bone marrow signal, the fatty marrow versus the red marrow or inflammatory marrow.
Great, thank you. And I'm just looking through, I don't think there are any particular other radiology questions, but I had a question for both Dr. Hryhorczuk and Dr. Ferguson that came through that I'm just going to pull up. And it's in regards to patients who present with pain and swelling with no radiographic findings, but have been treated with steroids and/or naproxen, and what would be the expected course where we'd expect to see radiographic findings after stopping therapy?
So I need a clarification. So using the term radiographic, are you meaning MRI or plain films only? So I think if plain films only, I mean, the ideal scenario is you would never have a destructive lesion that you could see on plain films. You pick it up fast enough on MRI, get it treated, and don't have any damage. But if you know, so a lot of patients never have an osteolytic lesion seen. They just have MR signal abnormalities. If you stop medications, you're always, at risk of flare, and those can, if not treated appropriately, cause an osteolytic lesion.
Thank you. I also wonder if the question may have been also if, for some reason, if someone had a normal MRI and they were treated with NSAIDs and then took them off. I don't know if you would anticipate in the future if you would see any like imaging findings or when that timing would be.
I don't think I would anticipate seeing imaging findings in those patients.
So I guess the question, I'm still a little bit confused. So you'd have to have some sort of radiologic imaging that helped you with the diagnosis, right? So at some point there has to be an abnormality to make the diagnosis. So then the question is, you treat them with NSAID steroids, you get another image, and now it looks good. If you stop the medication, would you have a return? And I would say there's always that risk of having disease activity return. We don't know how long to treat people. And so we don't know how long, how long's long enough before the flare risk is very small. We don't know when they're done. So there's no biomarker to say this child's not going to have a recurrence and this child is. So yeah, I would say that yes, if you stop therapy, that you're going to have a risk of having bone lesions return. With the scenario that I just made up, which may not be what you're after. And if so, clarify and we'll try to answer it better.
Okay, great. Well, maybe we'll move on to some other questions. I'll go from the beginning in the Q&A box. This one was for Dr. Ferguson. So do you avoid bisphosphonates in patients unwilling to take measures to avoid pregnancy? How do you counsel on the pregnancy category D for bisphosphonates?
Yeah, so I mean, in general, if you've got somebody who's of reproductive age and a female, I would tell them that this is maybe not the best drug for you. If they've failed a TNF inhibitor and want to proceed with a bisphosphonate, then we talk that they need to be on birth control. It would be the same as like for methotrexate. If somebody says they're not sexually active and does not want to do that, I just make sure I have a very thorough conversation about the consequences with them and document it in the chart. But I would not withhold therapy from somebody who will not start a birth control method when they say they don't need one. So as long as they're fully informed.
I want to ask you a quick follow-up question for that, but then I know we have another question for Dr. Hryhorczuk. But Dr. Ferguson, do you know, is there like a recommendation of how long to be off of bisphosphonates before a patient should get pregnant?
There really isn't good guidance. The half-life of those things is about a decade. I mean, they do seem to really bind to the bone tightly. If you look at the literature about birth defects, it's not there's not a big literature to guide you. And we have a lot of kids who got bisphosphonates for JIA, for cerebral palsy, for other metabolic bone diseases, and the signal for birth defects is not big, but it's not absent. So even getting dental work done. So you need osteoclasts to help you move teeth around your mouth. So braces are going to push and put pressure onto the bone. Osteoclasts help to reabsorb that bone. You're going to need to kind of come in and restabilize things. You're going to have the osteoblasts come and help you put that tooth back solidly into its new place. And so with bisphosphonate use, your teeth aren't necessarily going to move very fast, if at all. So that usually the orthodontist and dentist, will say to be a year post treatment before they would want to go ahead and proceed.
Thank you very much. And then Dr. Hryhorczuk, a question for you is similar to before, with the long-term imaging outcome of the linear densities noted post-bisphosphonate. I guess long-term, do you continue to see those on imaging like years later?
We continue to see it for quite a while. I'm not sure if we have people where I've seen good follow-up for like 10 years out from their treatment, but we certainly see it for a while.
Dr. Ferguson, a question for you from the participants. Children with no spine lesions, are there any clues in clinical or radiologic images that should guide us to choose anti-TNF methotrexate versus bisphosphonates?
Yeah, so that's a good question. And right now, the data looks like they're pretty similar. Shanabel's study looking at TNF versus bisphosphonates that I talked about, maybe TNF might be a little better, but that's not a randomized controlled trial. So I just talked to parents about these look fairly equivalent. These are the risks of one, these are the risks of the other. These is just for people who fail NSAIDs and get the parents' involvement in the decision making. The data for using a DMARD like methotrexate or sulfasalazine alone just doesn't look as robust. But again, we're working on data that's not, rigorously collected in a clinical trial. So if a family wants to do methotrexate or sulfasalazine alone, I have had patients who do that. So I just give them all the options and make shared decision making. During COVID, everyone was very frightened about the risk of serious infection with TNF inhibitors. More people chose bisphosphonates then, but I think now it's gone back to, it's really kind of 50-50. The bisphosphonates seem to help with bone pain more quickly. So somebody in really severe bone pain, it can be a good option. Even though it seems like using it for somebody who has jaw involvement would be more scary, there's maybe one abstract that was seen at a meeting by one of my colleagues in Europe of osteonecrosis of the jaw in a child. But it's incredibly rare. And the jaw pain with this disease, when it's involved, can be really quite severe. And so bisphosphonates do help that pretty rapidly.
Dr. Ferguson, for patients who have spinal lesions who achieve clinical remission fairly quickly with pembedronate, like say after several months, in your practice, how long do you usually continue for? Do you have a set period of time, 6 months, 12 months, or do you usually stop after they've achieved remission with therapy?
Yeah, so I tell them with the spine that we usually do 12 months minimum, and then reassess. But both with TNFs and bisphosphonates, it's not like everything goes away. So sometimes you get lucky and have somebody completely respond, but a lot of times they're substantially better. Their pain is better. They have fewer lesions. But it's not uncommon on either of those therapies to get a new lesion while they're being treated. So, how long to treat, whether we should continue to treat if somebody has, new radiographic lesions but doesn't have pain. All of these questions, there isn't a clear answer to. And so we're trying to more robustly collect data so that we can help get those answered.
Just to continue talking about bisphosphonates, I have two questions. One is, can we use zoledronic acid instead of pimidronate? And then another question is, what is your experience with alendronate with patients who want to do oral bisphosphonates?
Yeah, the oral bisphosphonate use is minimal. There's very little literature. I had one or two kind of older adolescents who had their rheumatologists, who were adult rheumatologists, using that. Neither of them got better. If they got an IV bisphosphonate, they improved. But that's a very small N. So there's just minimal data. And then pamidronate versus zoledronic acid is really, there isn't obviously a head-to-head. There are some places that only have one or the other on their pharmaceutical shelf. So there are some major pediatric hospitals that only have zoledronate or zoledronic acid now. We have the option to use both. There really isn't any great head-to-head. The one thing I will have, if somebody's really in a lot of pain, I find that pamidronate seems to be the most effective way to get them quieted, their pain controlled faster, in that we bring them in and give them the 3 doses in a row. Whereas if you look at zoledronic acid and what's recommended for how you start, it's like you get a small dose and then you come back and you get another dose. And so we've had kids who have done that and just not been controlled well with pain. But we use more pamidronate. So my personal experience is more pamidronate. There was did you see the one question too about rank ligand inhibitors?
Yeah, I was going to pull it up.
Okay. I
Let's
saw that one.
see.
It's just an easy one to answer while
Sure,
we're
yeah.
continuing to look.
So the question is if rank ligand inhibition has been looked at, if it has more of an effect on IL-6 and IL-1 than bisphosphonates.
Yeah, so really it hasn't been looked at. I don't really think there's been much in the way of abstracts or case reports either. So limited data.
Okay, and then the question right after that, curious to know if patients who develop TNF inhibitor psoriasis also have worsening disease.
No.
There's often go ahead.
Yeah, not usually. Usually it's just all of a sudden they have an explosion of psoriasis, mostly in the scalp. A lot of kids come with, really substantial alopecia. I was editing that slide as I was watching myself talk. I'm like, that slide has lots of little bad mistakes in it, like alopecia. So anyway, forgive that slide. It's now fixed for future slides, but no, they don't necessarily come like a flare. So there's going to be some risk, right, of getting psoriasis with the disease. It occurred long before we had TNF inhibitors. So, but how to tease out which is which is tough to do. So if somebody's on a TNF inhibitor, they get horrible scalp psoriasis with lots of alopecia. I just assume that's drug induced and come up with a plan to get them off or switch to another therapy for a while or to Simponi or something different. We've had some trouble getting insurance to approve like phototherapy and things like that for our pediatric patients. But using topicals and other, mechanisms to try to help it without systemic therapy. We have used a lot of methotrexate. Mostly I use it because if a TNF inhibitor is your magic and the kids are doing great, like the last thing you want them to do is to develop an antibody to the TNF inhibitor and have it not work. So the data looks like the use of methotrexate in conjunction with TNF inhibitors reduces that risk. So that's my main reason for using it. But we haven't had a lot of psoriasis happening in the kids who are on both. But I also, if they're not on methotrexate and they get this psoriatic reaction or just get psoriasis, I would make sure that you can like maximize things that are easily available, and like methotrexate would be one option.
Another question from the participant. 2 questions. How long do you use NSAIDs? And second, for resistant spine disease with vertebral fractures, would you use both a bisphosphonate and anti-TNF inhibitor at the same time?
Okay, so the NSAID question is really, if somebody's in a lot of pain in a month, but to me that's, that's a month too long. So, but most people would say like trying, 3-4 months, depends on their level of pain. So that's just kind of for me is pain driven. If they're not doing well, I'm not going to make them spend a specific amount of time on an NSAID without switching. And then, yes, we do have some who get a TNF inhibitor and a bisphosphonate at the same time. And there is some literature of people doing that up front. So if you fail an NSAID, you go on both. But my experience is that either pamidronate or TNF inhibition is pretty effective. And so with just one. And so I don't want to expose a lot of kids to two drugs when one would be good enough. So, but if they're not fully responding, I always, and this is a take-home point, somebody is not responding to standard medicines for this disease, think again, are you wrong? Rebiopsy or biopsy for the first time. Not everybody needs a biopsy, especially if somebody comes to my clinic, I see so much CRMO. If they have pulmonary pustulosis and they've got a clavicle, you're done, right? You don't need a biopsy. So, not everyone needs a biopsy, but if it is a diagnosis of exclusion, you can't make the diagnosis radiographically, really, or clinically, unless they've got another comorbid condition that makes it pretty clear. So you have to exclude everything else. And if they don't respond to therapy, always rethink your diagnosis. Could you be wrong? And then start taking food histories. We've just had this flurry of, autistic children that are not eating fruits and vegetables at all. So, yeah. And that's much easier to fix than CRMO.
Thank you. And then another question from a participant. So a delay in diagnosis is a strong factor in developing amplified pain. Do you think there's a role in more aggressive initial therapy in reducing the development of amplified pain, such as dual or triple therapy as the initial treatment?
Well, I don't think we have data to say that we need to be aggressive up front, more aggressive up front just to prevent pain. I think the problem really is the delay of diagnosis, not necessarily treatment. Some people might undertreat, and that is true. I would say that, there is this tendency, I think it's kind of being dispelled, that this is just a benign disease and all will go away. And, just take some naproxen or ibuprofen or whatever instead of your choice, and it'll be fine, and have the kids continue to have pain. So I would say, don't leave them in pain. If if your treatment isn't providing the pain relief that's disease associated, escalate therapy. And really make sure that if you change therapy, I get imaging again. So I want to know where I'm starting, because there's a lot of times when somebody is in a lot of pain, they say, this is my CRMO, and we get a whole body MRI is totally clean. And so, you really need that to tease out pain amplification, because none of the medicines I'm going to give, besides like naproxen as a general pain relieving thing, is going to help that type of pain. So then I would be putting them, exposing them to a TNF inhibitor or a bisphosphonate when that wouldn't physiologically help the cause of their pain.
And we had another question just come through. For children in remission while on treatment, would a radiological asymptomatic new lesion prompt you to change therapy?
Yeah, so this is very interesting. We just had a voting panel, coming up with kind of, parameters of like, what's a flare, and there's a huge discrepancy in the room, with a lot of experts where some, if it doesn't hurt, it doesn't care. They don't care unless it's in the spine. For me, it's like if they have a bony bar or a trans, growth plate lesion, if they're getting a leg length discrepancy, there are things that happen that don't hurt but can cause damage. So I think you just have to really kind of look at the whole picture. If there's a small, new lesion in the proximal tibia, it doesn't hurt. I would not treat that specifically. But it gets to be now there's 19 new lesions, is that okay? They don't hurt. There is not a clear answer, and experts internationally would have a kind of a broad range of what's too much for each individual. So we're trying to come up with consensus on that. I don't have the data back yet, but we'll see.
Thank you very much. And I know Dr. Hryhorczuk has to step away, so I just also want to thank her for her participation in the helpful talk this morning.
Thank you so much. I enjoyed being a part of this really nice educational opportunity. Thank you.
Thank you, Anastasia.
Thank you. And then Dr. Ferguson, I just going to look through, there's one more question that looks like it's unanswered. And let me just see, it was, if we have clinical improvement, but there are new lesions in MRI, should we wait and see if, or should we change treatment? Let's see. I guess you kind of already answered some of this, I think, before, so I think we're good there, actually.
Yeah, I think you need to talk to the family about things, but is it in a risky place for long-term damage? What are the risks of, escalating your therapy in a child that doesn't have any pain? What are you going to follow? It gets to be kind of complicated. I would say that's where I get a lot of, second, third, fourth opinion visits is, it's pretty straightforward to start the treatment but it gets kind of muddy, it's like, what do you do? So we are trying to clarify things, but I'd say right now it's still pretty muddy about what to do. Yeah. But if you stop therapy and they've got lots of lesions, it's likely that something is going to return as a clinical symptom.
Thank you so much, Dr. Ferguson. Again, I'd like to thank you and Dr. Hryhorczuk for your excellent talks this morning and a great post-talk discussion, as well as for the attendees for their participation in the live chat. Please don't forget to claim CME credit for your participation in today's activities. The link is in the chat, and if you have any questions or concerns claiming CME credit, there is an email to reach out to us. And again, thank you for everyone's attention this morning.
Thanks for the invite. Take care all.
Thank you for being part of this edition of NICER's Education Camp. Join us live or listen to the recorded session on the NICER YouTube channel at NICER Consortium and on our NICER website, nicerconsortium.org, where you can find all the Education Camp sessions and more.